Hello and welcome to another emergency questions and answers for families in intensive care and intensive care at home. My name is Patrick Hutzel and I want to welcome you to this live stream, and I also want to welcome you if you are watching this on replay. We will be going for up to an hour here and I will answer your questions live on this show. You can type your questions into the chat pad, or you can join me live and talk to me directly by clicking on the StreamYard link that I'm posting into the chat pad right now. And you're welcome to join me here. Now, before we go into today's questions, what makes me qualified to answer questions for families in intensive care and intensive care at home? I am a critical care nurse by background. I have been working in critical care for nearly 25 years in 3 different countries, where I worked as a nurse manager for over 5 years. And I've been consulting and advocating for families in intensive care all around the world since 2013 here at intensivecarehotline.com. And I can confidently say that we have saved many lives with our consulting and advocacy. And you can verify that on our testimonial section at intensivecarehotline.com. And you can also verify it on our intensivecarehotline.com podcast, where we've done some client interviews. I am also the founder and managing director of intensivecareathome.com. With Intensive Care at Home, we are providing a genuine alternative to a long-term stay in intensive care, predominantly for long-term ventilated adults and children with tracheostomies, as well as home BiPAP, home CPAP, non-invasive ventilation, tracheostomy care for clients that are not ventilated, home TPN, home potassium, magnesium infusions, home IV antibiotics, port management, central line management, PICC line management, as well as Hickman's line management. We're also sending our critical care nurses into the home for emergency department bypass services. And again, similar to intensive care hotline, with intensive care at home, we have saved many lives getting patients home from intensive care instead of going down the route of withdrawal of treatment because of no perceived alternatives. We are that alternative. It's more than a perception, it's actually a reality. We are a reality with intensive care at home, and we can help you. If you're watching this, you're an ICU doctor, ICU nurse, hospital executive. If you're watching this, we can help your family, your patients, to live a better life at home when they're stuck in ICU long-term, or if they're coming back to your ED emergency department over and over again for the same things. Now, without further ado, and with intensive care at home, before we go into the questions with intensive care at home, we are currently operating all around Australia in all major capital cities. All of our critical care nurses have a minimum of 2 years critical care nursing experience. As a matter of fact, we're employing hundreds of years of intensive care and critical care nursing experience combined. We are the only service provider in Australia in 2024 that has achieved third-party accreditation for intensive care at home nursing. We can operate under the NDIS scheme, TAC in Victoria, WorkSafe in Victoria, iCare in New South Wales, NIISQ in Queensland, as well as the DVA, the Department of Veteran Affairs, all around the country. We're also providing level 2 and level 3 NDIS support coordination. Okay, let's carry on with the first question that comes from Peter, who says, "Hi Patrick, my mum is 78 and still not reacting in ICU after open heart surgery. Her blood pressure is 119/45. She opens her eyes and her breathing is very fast and her body is ice cold. What are her chances of survival?" Well, that's a very good question, Peter. So it really depends on why she had open heart surgery. So what do I mean by that? Some patients go into intensive care after open heart surgery for an elective open heart surgery. That could be coronary artery bypass grafts, it could be a valve repair, it could be a valve replacement, it could be the mitral valve repair, an aortic valve repair replacement, tricuspid valve repair replacement. So it really depends which valve. Is it elective? Is it emergency? If it's elective, chances are, that it's very controlled, and that patients go into surgery and, they're being woken up after surgery, assuming there's no complication, assuming they're not bleeding, assuming there's no cardiac arrhythmias, assuming they are hemodynamically stable, right, and so forth. If they are not hemodynamically stable, right, and there's complications such as bleeding, irregular heart rhythms, cold body, then they can't be woken up, and they need to stay in an induced coma for more than 24 hours, right? So again, let's paint the ideal scenario. And, I've looked after probably hundreds of those patients. So let's look at the ideal scenario. Someone comes back from surgery, whether it's, again, coronary artery bypass grafts, whether it's valve repairs, valve replacements. You warm them up because they're cold after surgery. You warm up the patient's body. You make sure they're hemodynamically stable. You monitor whether there's any bleeding from the chest, right, after the sternotomy, after they've cracked open the chest. You monitor their vital signs and so forth. And if everything is stable, you keep them overnight, and then you wake them up, get them out of the induced coma overnight, and ideally the next day you take them off the breathing tube, and then they're off to a cardiac ward. Now, that is the ideal scenario. Now, there are other patients that go into ICU after open heart surgery that are coming in as an emergency case, which means they have open heart surgery because they need it right now. Maybe they had a heart attack. Maybe they had a collapse because the valve is no longer working. Maybe they had a bleed on the heart, whatever the case may be. Maybe they had a clot on the heart. In any case, it was emergency. They had to be rushed to the catheter lab. They had to be rushed to the emergency theater for open heart surgery. And then patients are much more unstable, generally speaking, when they come back. And then they're going off the pathway. What I've described to you earlier is more or less the pathway, that when patients are stable, they follow a pathway. Do this at 10 o'clock, do this at 12 o'clock, do this at 1 o'clock, wake them up at 2 o'clock, titrate, propofol down, titrate morphine or fentanyl down, and so forth. That's all off the cards if it's an emergency, which I think it is probably an emergency here, Peter, for your mom. Things are not going as planned, right? Your mom might have had prolonged surgery to begin with, right? If she had prolonged surgery to begin with, her waking up phase is much longer, right? If she had emergency surgery, the risk of complications is much higher, i.e., she might have an irregular heart rhythm. She might be bleeding, right? She might be hemodynamically compromised, needing inotropes, vasopressors, or potentially vasodilators, right? She might be attached to a pacemaker box after cardiac surgery, which can happen after cardiac surgery as well. Worst case scenario is she might be on ECMO, right? But you haven't mentioned that, and I do believe you would know if your mom is on ECMO or not. So her blood pressure is 119/45. That is fairly stable. However, she might have a blood pressure of 119/45 if she, she might be on vasopressors. She might be on inotropes. She might be on vasodilators. Okay. So also her breathing is very, very fast. That means they might be trying to wake her up, but she's not cooperating yet, right? If her breathing is very fast, she might be in a lot of pain, right? So she might need some solid pain relief. And that's where it's also a catch-22. After open heart surgery, people have a sternotomy. What that means is the chest is literally cracked open to get access to the heart, right? And that is extremely painful. So when patients come back after surgery, they do need very solid pain relief. Very solid pain relief. So what I mean by that is they need to be on, small to medium amounts of morphine or fentanyl, right, to take the pressure off or to take away the pain. Now, if breathing is very fast and pain is the issue, then, again, fentanyl or morphine need to be given. That will definitely slow down her breathing rate, because one of the main side effects of fentanyl and morphine, or any opiate for that matter, is respiratory depression, right? And with respiratory depression, it means that, breathing will be slowed down. Now, the sooner someone can be taken off the ventilator and extubated and breathe independently without much pain, that is absolutely the preference. But that doesn't look like it's happening right now with your mom here, Peter. And it's probably not happening because things are not going as planned, right? So, but to answer your question, what are her chances of survival? Well, a lot of it comes down to why did she have cardiac surgery or open heart surgery? Is it because she had a heart attack and she needed coronary artery bypass grafts? Is it because she had a valve repair or a valve replacement, right? And the heart wasn't functioning properly because of that, right? So most patients that I've seen in ICU after cardiac surgery do survive, and they do leave ICU alive, right? So also in the bigger scheme of things, Peter, approximately 90% of intensive care patients survive. There's research out there. So why should your mom not survive, right? But your question in the realm of cardiac surgery or open heart surgery is very broad. It is very, very broad, I would want to know what medications she's on. I would want to know how long the surgery was. I would want to know what type of open heart surgery she had, as I just explained. I would want to know whether she went into the catheter lab before she went into surgery, which is not unusual with cardiac surgery or leading up to cardiac surgery, right? And if her body is ice cold, I also argue she might have two things there. Surgery might have taken a long time. That's number one. And number two, she might have had, she might be on inotropes or vasopressors, because that will also cool the body down, because with a vasopressor, the body will shut down to get all the blood to the heart. And that's why she might feel so cold. So you should be asking all of those questions: what medications she's on, what are the blood results, is she bleeding, is she having an irregular heart rhythm? If she has an irregular heart rhythm, what are they going to do about it? Are they going to correct that with amiodarone if she's in AF, atrial fibrillation? Does she need a pacemaker box for now? Does she have pacemaker wires? Those are questions you should be asking. So I hope that helps you understand what's happening and what you should be paying attention to. I'm pretty sure I wrote an article and made a video a few years ago. How long does it take to wake up after cardiac surgery? I also encourage you to type that into the chat pad, into the search box on our website, intensivecarehotline.com, or type into Google, how long does it take to wake up after cardiac surgery, intensive care hotline, and you should also see, some answers there. So I've covered this topic definitely before. Okay, so let's move on to the next question, which comes from Lynn. And Lynn writes, "Hi Patrick, my sister had a fall on a holiday. She fell down some stairs. We all thought she maybe tripped up, to find out she had an aneurysm which burst and 2 fractures on the brain. And they said she has a very serious head injury. She was hospitalized in Spain and put into an induced coma for 3 weeks. Then she was flown back home to Edinburgh Royal Infirmary. They took her out of the induced coma after a week, but she still needs the ventilator to help her breathe, but there's no response at all from her. They are saying they are not happy with her progress. She's been lying flat since it happened. So they said they're going to try and sitting her up to see if it helps at one point. The kid said, "Mum, if you know we are here, move your finger. Move your head, stick out your tongue," which she did on a couple of occasions. She has opened her eyes, but nothing really more than that. We all know she's seriously ill, but really need to know her chances of her recovering, as they think they're going to give up on her very soon, and too soon. I hope we can find some comfort in your reply. From Lynn. Okay. Well, the good news is, it sounds to me like something's there. So she's responding to, move your finger, move your head, stick out your tongue. So that's a good sign after 3 weeks in an induced coma, and after 3 weeks, on a ventilator, which she needed after the aneurysm and 2 fractures on the brain, and with a very serious head injury. So here's what happens. When someone has a serious head injury and has been in an induced coma for 3 weeks, right? They're not going to wake up like you're switching on a light. They're going to wake up more like switching on a light with a dimmer. Okay, and this is probably what's happening here. Some of the challenges your sister is facing now is, how can she be rehabilitated so she can maximize her quality of life, right? Imagine you've been in bed for 3 weeks in an induced coma due to a brain injury. You're not going to wake up, like someone is switching on a light. It's a very gradual and very slow process. What needs to happen here is your sister needs to be stimulated, i.e., she needs to have physical therapy, right? She needs to get mobilized, she needs to get stimulated. Another thing that you haven't mentioned, but I would think has happened after 3 weeks, she would have a tracheostomy, right? I would hope that she would have a tracheostomy by now, right? So with a tracheostomy, she should be off all sedatives, all opiates, right? And the focus should be on neurological rehabilitation, which would include physical therapy, mobilization, so that she can get more aware of her surroundings, that she can start to move again. One of the biggest challenges with an induced coma of about 3 weeks is simply that your mom would be deconditioned, right? Every day that someone is in an induced coma, the body deconditions, there's muscle wastage, and that happens pretty quickly, right? That is one of the biggest challenges when someone is going into an induced coma, that, there's real deconditioning happening. And the longer patients are in an induced coma, right, the longer rehabilitation takes, right? The longer it takes for someone to get back on their feet again, right? And there's also the question, of course, how significant is the brain damage? Have you spoken to a neurologist to get their prognosis, right? That is really important that you ask all those questions. Also, is she having seizures? Here is why. After head or brain injury, some patients might have seizures, right? If they have seizures, they also need anti-seizure medications. If they need anti-seizure medications, they also have sedative effects. Most anti-seizure medications that are being used in ICU are Keppra or phenytoin, also known as Dilantin, and they have some sedative effect as well, potentially delaying waking up, right? So please ask all of those questions. The next question is, how far away is your mom from getting off the ventilator, right? The sooner she can come off the ventilator, the better, right? If she can't come off the ventilator, she still has to be mobilized. One of the most important things that needs to happen now, Lynn, is she needs to be mobilized, right? That will show you pretty quickly what she can and what she can't do, right? That is going to be really, really important. And, can I give you comfort? Look, my job is not to give you comfort. My job is to educate you and make sure that you can make the right decision here. That really is my job. You know, you need to make the right decision for what is right for you and your family. It's not about me, right? It's not about me. It's really all about, you know, what you want out of this situation, right? I hope that helps answer you that question, Lynn, what to do next, you know, and don't make decisions today that you might regret in about 12 months or 24 months time, right? That is really important that you make decisions today that you don't regret in 12 months time, in 24 months time, right? Because if you make decisions today that you will regret, that is certainly not a good idea, because then you come back in 12 months time and you say, oh, if I only had made this decision, right? But then it's too late. Okay. So in the meantime, if you're live on the stream here, if you have any questions, please type them into the chat pad or join me live on the stream by clicking on the StreamYard link that I posted in the chat pad here, right? Next comment and question that came in during the week was, I posted a video about a testimonial this week, and then Janet comments on that video and says, hi Patrick, I wish I had known about your consulting and advocacy for families in intensive care when my husband was in ICU with COVID. They murdered him. Well, Janet, I'm very sorry to hear that. I think what you should do in a situation like that to get some closure, you should let us have a look at the medical records so we can find out whether there has been medical negligence or not. So that would be my advice here. Unfortunately, it's too late, and it's just another word of warning that you can't get consulting and advocacy early enough. You can't do your own research early enough, right? You don't want be in a similar situation than Janet, where all of a sudden you realize things didn't go as you wanted them to go. You don't want that. You can't afford that. That's why I'm saying you are in a once-in-a-lifetime situation that you simply can't afford to get wrong. Hi, James. Nice to see you. What are your questions? Type in your questions, please. In the meantime, James, while I'm waiting for you, I will read out the next question from Julie. And Julie writes in, hi, Patrick. Oh, there's James. When I carefully examined my dad's medical record, I found that dad's nasogastric tube, KEO tube, was clogged 12 of the last 14 days. This was hidden from us. Right. Wow. So that means your dad potentially didn't get any nutrition and not enough hydration for about 12 days. Right? Is that what you're implying here, James? Is that what you're implying? That your dad potentially didn't have any or not enough or insufficient food for 12 out of 14 days? Is that what you're implying here, James? James, you can also join me on the StreamYard link and talk to me directly. I think that way we can get your questions answered much quicker. The StreamYard link, I'll just put that in here again. What are the chances that it's clogged that long? Not very high, I'd say. A good ICU will change the tube. A good ICU will change the tube almost immediately, right? That would be my answer to that. That would be my answer to that, James. I believe you're saying you believe it was sabotaged. I would need to know more context. They changed the tube a couple of times. Yeah, but if they changed the tube, why If they changed the tube, then it should have been up and running again. It should have been up and running again if they changed the tube. Rick, welcome to the show. Rick says, what are your thoughts on brain flow angiography studies for brain death diagnosis? Yeah, it can be part of it. It can be part of it, but there is a rigorous testing that needs to happen for brain death, and I will quickly run you through that, right? What it includes. So brain death testing is, the definition is, it's irreversible loss of all functions of the brain, including the brainstem, right? The three essential findings in brain death are coma, which is unresponsiveness, absence of brainstem reflexes, and apnea. So what needs to happen then is, cause for coma consistent with brain death, at least 4 hours of observations during preconditions must be met, Glasgow Coma scale of 3, pupils non-reactive to light, no cough, apnea, right? The neurology imaging needs to be consistent with acute brain pathology that could cause brain death. Now, examination is absence of responsiveness, absence of brainstem reflexes, apnea. The procedure is trainer 4 nerve stimulation tests, with 40 millivolts to rule out neuromuscular blockade. Glasgow Coma scale of 3, no response in even when you do deep nail back pain on all 4 limbs, even with a needle, right? That would be very painful. Pupils fixed, no reaction to light, no corneal reflex, no ocular vestibular reflexes, no gag and no cough reflex. Positive apnea test after pre-oxygenation and pH 7.3, no breath taken after disconnection from ventilator with PaCO2 greater than 60 millimeter per mercury or increase in PCO2 by 20 millimeter per mercury if COPD, asthma, or CO2 retainer. The test needs to happen by independent examination by 2 suitably trained and experienced doctors, can be sequential, don't have to wait 2 hours between testing. Time of death is the time of completion of the second examination, right? Now, investigations, and this brings me to your question, Rick. The indication for cerebral perfusion imaging, right, which is a flow angiography, is when clinical brain death cannot be determined. Any of the preconditions that I have just mentioned cannot be met. That's when flow angiography is probably indicated, right? And then the article here continues, an investigation showing absent cerebral parenchymal blood flow is required. 4-vessel angiogram, no flow above the carotid siphon in arterial circulation and foramen magnum. And this is very clinical. CT angiography, right? Of course, and it says less experience with this technique, absent enhancement at 60 seconds in different cerebral arterial distributions, presence of contrast in external carotid artery must occur to establish a technically adequate study. Transcranial Doppler may be used as a screening test to optimize the timing of the contrast study. Brain death is generally preceded by increasing intracranial pressure. Following brain death, a predictable pattern of multi-organ failure ensues. So, Rick, I hope that answers your questions, that, you should be asking for that if you are unsure. Maybe you give me more context, Rick, why you want the brain flow angiography. I don't know your situation. I think you've been on the show here before as well. Give me more context. Why are you asking for brain flow angiography? Okay, James, you're saying there was a kink right at the entrance of Dad's nose. Okay, I would imagine you are referring to the nasogastric tube. There was a kink. And another time there was a sharp nick cut at Dad's nose. I have a photo of the cut. Dad was deemed stable and improved enough to be discharged from the ICU the next day. This one palliative doctor decides on his own to not provide a peg whether Dad could swallow or not. This decision was made with no informed consent from the patient. Well, what have I been saying since 2013 here on this video, on my videos here and blog posts? They can't just do anything without your consent. And if you let them get away with it, it means you haven't had enough time or insights at the time that you have rights, and you didn't activate or exercise those rights. Now, if there was a kink in your dad's nose or in the nasogastric tube of your dad's nose, they should have changed the nasogastric tube, right? But how was he deemed to be stable, to be discharged from ICU if he hasn't had nutrition for 12 days, which is what you are implying, right? I argue a PEG was not needed if they had changed the nasogastric tube, right? And was he discharged from ICU to go into palliative care, to go into hospice? Was that the plan? Did you know what was happening at the time? In either way, in either case, if your dad didn't have nutrition for 12 days and he didn't have TPN, do you know if he had TPN, which is IV nutrition, right? Do you know that? So I'm just trying to get to the bottom of it all here. Whether, he had any form of nutrition, or whether they deliberately withheld nutrition for 12 days and they were already palliating him, already commencing end-of-life care by starving him, which is illegal, right? So you're saying the 12 days of starvation was after discharge from ICU, IV was for fluids only. Okay, all right. So were they then discharging him from ICU to deliberately starve him to death because he was discharged into the hands of palliative care? Because you're saying here he was discharged from ICU. The next day, this one palliative care doctor decides on his own to not provide a PEG tube, whether that could swallow or not. So I'm wondering, it has to be it was a setup. They were setting him up to basically starve to death. That's what it sounds like to me. Right? So they said in the first meeting they wanted to only give 5 days of feeding trial, and they wanted to pull out the nasogastric tube, KO tube. And then what? And then after what? And then do what? Let him eat orally again? Let him eat orally again? Also, why was your dad in ICU to begin with? Did he have a brain injury? For example, if he had a brain injury and he couldn't swallow, right? Then if he couldn't swallow, he needed nutrition one way or another. But one hospitalist put the nasogastric tube back in. Okay, so then why was he not fed? Or was he fed? That was in ICU due to aspiration pneumonia. Okay. And then once he left ICU, he would have been extubated. He wouldn't have been on the ventilator, or did he have a tracheostomy? So if he was off the ventilator, didn't need a tracheostomy after the pneumonia, due to oropharyngeal dysphagia, this was his first time. Okay, so that means he couldn't swallow. Well, if he couldn't swallow, then he needed a nasogastric tube or a PEG tube. He was extubated. Okay, all right. Well, even worse then, if he was extubated and he needed nutrition, right? Why couldn't they feed him? What's the problem? He was awake, conscious, and communicating with the family. Okay. Did he have speech therapy? Yeah. Look, whether PEG or nasogastric tube was necessary, that's not the point. The point is he needed nutrition. And that nutrition should have been given one of 3 ways: nasogastric tube, PEG tube, or TPN, right? One way or another, James, he needed a PEG tube. He needed nutrition. Didn't matter which route. If he couldn't swallow with dysphagia, he needed some nutrition, right? Did he have speech therapy? Did he have swallowing assessments done? Right? I would be very curious to know that. Their plan was to let Dad continue to aspirate, and he died 70 days later due to suffocation. So how could he aspirate? Were they giving him oral feeds, or was he aspirating his saliva? Yes, he had a swallowing assessment, okay. But why did he aspirate? Did they give him oral feeds, or did he aspirate on his own saliva? Now, here's what I can see, James. He was extubated, okay, that's great. But if he couldn't swallow, right, he would have still needed a tracheostomy to protect his airway, right? If he could not swallow his saliva and he got extubated, he had no airway protection whatsoever, which is, again, why he would have needed a tracheostomy from, if I understand this situation correctly. Right? So, James, have I answered your question here? Because if I have, then I will move on to the next question that came in during the week. Or if anyone on this call wants to ask any questions, type them into the chat pad, or join me live on the StreamYard link here. You can join me on the StreamYard link here and talk to me directly. Okay, James, you're asking what's the purpose of a tracheostomy? Yep, good question. So, a number of purposes. Let's start with the first one. If someone can't be weaned off the ventilator with a breathing tube, right, then after about 10 to 14 days of intubation with a breathing tube, you need to do a tracheostomy. What I will do is I will show you a tracheostomy. Just give me 1 second. So you can actually see what the purpose is of a tracheostomy. So this is a tracheostomy here. Okay, it sits in a patient's neck, right? So here's the purpose. So it is to connect someone to a ventilator. Okay, that's one purpose of a tracheostomy. In your dad's case, who no longer needed a ventilator, he would have needed a tracheostomy to protect his airway from aspiration, right? And here is how that works. So when someone has a tracheostomy in their neck and they can breathe independently, that's fine. Here's what makes the difference, would have made the difference potentially to your dad. Can you see that balloon that I'm inflating now? Can you see that? Right? This balloon protects an airway from aspiration, right? Once that balloon is up, if your dad can't swallow, that balloon stops saliva to go down the lungs, causing an aspiration pneumonia, right? So that is the purpose of a tracheostomy, or would have been the purpose of a tracheostomy in your dad's case. So it's not, tracheostomy has the purpose of helping patients to wean off the ventilator, helping patients to have long-term ventilation if they need that, but also having the purpose of preventing aspiration. So now you're asking, if dad is having difficulty swallowing, what are his chances of him choking on his own saliva? Very high, right? That's where the tracheostomy is coming in, right? Chances are very high that he aspirated on his own saliva and then ended up with an aspiration pneumonia, which sounds like it might have killed him. No, a PEG tube, you're asking, James, wouldn't a PEG achieve the same goal? No. So let's quickly map out the difference between a nasogastric tube and a PEG tube. Both nasogastric tubes and PEG tubes are sitting in the stomach. The difference is that the nasogastric tube goes through the nose, ends up in the stomach, and the PEG tube goes through the abdominal wall, sitting in the stomach, right? So a PEG tube has nothing to do with swallowing whatsoever. The only thing that, the correlation with swallowing with the PEG tube is if someone can't swallow, how do they get nutrition? Do they get nutrition through a nasogastric tube or through a PEG tube? That's the question here, or potentially via TPN. Wouldn't PEG have prevented that from suffocating? No. Not at all. No. I think you're mixing up terminology here, James. A PEG tube is a percutaneous endoscopic gastrostomy, enabling patients to receive enteral nutrition through a PEG tube that goes into the stomach. A tracheostomy sits in the neck. It has very different functions. PEG tube, very different function compared to a tracheostomy. Has nothing to do with preventing your dad from suffocating. The only thing that it did with the suffocating part is he didn't take oral nutrition. Let's just say he had a PEG. Okay. Yes, he wouldn't swallow food because he's got a PEG. However, that still puts him at risk of aspirating his saliva. Right? PEG, yeah, would have prevented. Yes, it prevents aspirating food. Yeah, it does. But aspirating food particles, yeah, because your dad wouldn't eat orally, for sure. But that's still, whether anything orally, whether it's saliva or food, and he can't swallow, that still puts him at risk of an aspiration pneumonia. Right? Does that make sense, James? So now you're saying that dad would have not suffocated from saliva. Well, that's the part I don't know. But if you are telling me, when I look through your messages here, you are saying, what are you saying? You are saying here in one of your messages that their plan was to let dad continue to aspirate, and he died 17 days later due to suffocation. What did he suffocate from? Did he suffocate from an aspiration pneumonia? Right? So they let dad aspirate so much particles for 70 days. What do you mean by that? Did they give him oral food? If your dad could not swallow, he would have suffocated from his own saliva. He would have. He would have ended up with an aspiration pneumonia. And what do you mean they let dad aspirate so much particles for 70 days? Do you mean by that they were giving him food and he was coughing on it? Is that what you're indicating to me? All right. Why you are okay, you're saying, what are you saying? 2 spoonfuls of mashed potatoes pushed him over the edge. Yeah, I'm not surprised. If he couldn't swallow, then absolutely, then I'm not surprised. I had to take that home. Okay, did you take him home to let him die at home? Is that what you did? Right. But irregardless, James, even if you took your dad home and he couldn't swallow, the outcome would have been the same. He would have aspirated one way or another. If he aspirated, if he was at risk of aspiration, whether it's with food, whether it's with saliva, he would have needed a tracheostomy, and he would have needed a PEG tube or a nasogastric tube. That's usually what is safe in a situation like that. Right? They cover up too important information. Yeah. Yeah. I also think, you might need a medical expert to look at these notes. We can do that for you. Yeah, the status of your dad's swallow function. Yeah, definitely. And what else did they cover up? How much nutrition he had. Right. How much nutrition did your dad have? And was it sufficient? Because if he didn't have enough nutrition and he was aspirating, he was probably dying from an aspiration pneumonia and from malnutrition. Yeah, and the existence of PEG and tracheostomy. Yeah. They probably never told you about a tracheostomy by the sounds of things. You asked earlier, what's the purpose of a tracheostomy? It sounds to me like they never told you about a tracheostomy. The biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. It's exactly what you were facing there. Practically no nutrition for 17 days. They fatally weakened him. Absolutely. Enough research is out there, James, that you can only fight a critical illness with adequate nutrition. Right? It's common sense. Just because you're ill doesn't mean you don't need nutrition. You know, very simple. Very simple. Okay, James, if you have no other questions, I'll move on to the next question that came in during the week. Or if anybody else on the call has questions, please type them into the chat pad, or join me live on the StreamYard link here. And click on the link and join me live on the StreamYard link, and I will talk to you directly. James, you're saying, I'm in the process of paying for a medical expert to examine and write a certificate of merit. Yeah, I would strongly recommend you do that. Strongly recommend you to do that. Right? We can also do that for you. We offer the same service. Right? We employ legal nurse consultants that look at medical records that can help you with getting the certificates of merit. But it sounds to me like there's a lot of unanswered questions. Now, James, I'm not sure which country you're in, but I'll give you another tip. There are some hospitals in the US. I'm not sure whether you're in the US or in Canada or in the UK or in Australia or somewhere else even. Some hospitals in the US, there's a documentary out there from CBN, I believe, where they clearly showcase that some hospitals in the US get extra payments when they move patients to hospice or palliative care and let them die. It's outrageous. It is absolutely outrageous. Right? Yes, I could potentially, yes, we do have doctors on our books as well. You could produce a certificate of merit from a doctor. Yeah. Just reach out to us through the website at intensivecarehotline.com. You can give me a call on one of the numbers on the top of our website, or send an email to support@intensivecarehotline.com. Right? And your dad might have been one of those cases in the US where he was in one of those hospitals where the hospitals might have benefited from getting extra payments when they move patients to hospice or to palliative care. It is outrageous, right? It's a case of population control. Is it a case of doctors wanting to play God? Okay. Let me go to an email that came in from Ashley, who says, "Hi, Patrick. My dad had a spleen infarct that they didn't seem to pay too much attention to. He was hallucinating a little bit and had to be put on CPAP. Only discovered throughout the time in the hospital he had sleep apnea and diabetes due to the steroids they have been giving him. While on the CPAP, when I last saw him, he was okay. Before putting him on the CPAP, he had a very low blood pressure, lowest being 75/45. They were able to stabilize it in rehab, so that's when I left him thinking he would be okay. His girlfriend stayed with him, and 1 minute he was telling her he was okay, to the next minute the monitor beeping and him being completely unresponsive, not waking up. They rushed him down to the ICU and discovered he had a massive blood clot and infarct in his lungs, which he needed to be put on ECMO for. Right, so he had a PE, a pulmonary embolus. Then I do have hope he will pull through, because he pulled through once before. I am at a loss of words, because all day today, me and my family told the nurses there was something wrong. I am constantly praying, hoping he will pull through again. My dad has to make it. What should I expect?" Well, thank you, Ashley, for writing in that much detail, and I'm very sorry to hear your dad's situation. Well, I'm glad, on the one hand, I'm very glad that they did all the right things and putting him on ECMO if that saved his life for now. So here's what you can expect. So he had a pulmonary embolus, right, which blocked his heart working properly, which is probably why he had a cardiac arrest, which is why they put him on ECMO. So now the ECMO is taking over the function of the heart. He would be on multiple vasopressors, inotropes, right? He would be in an induced coma. He would be ventilated. He would have a breathing tube. He would also be on high doses of blood thinners, most likely heparin. The reason he would be on heparin is because he had the blood clot, the PE, the infarct, right? So that needs to be dissolved. But also, now that there's a lot of blood being filtered through the ECMO machine, there's also a very high risk of blood clots because the blood will go through plastic tubes. And that is a very high risk for clots to develop, right? So, next, monitor beeping, completely unresponsive, and you could see that something was wrong. You were telling the nurses something was wrong because you know your dad, right? So what needs to happen and what can you expect? Your dad will need to be stabilized. Once your dad is stabilized, he will have a cardiac ultrasound. He might even have a TOE, a transesophageal echocardiogram, right? They will measure your dad's ejection fraction, which is the contractility of the heart, right? Once that is all more stable and he can be weaned off inotropes and vasopressors, and the cardiac output is good on the ECMO, they will slowly but gradually reduce the output, the cardiac output on the ECMO, the flow, right? And once the flow can be gradually reduced over the next few days, hopefully, right, and the cardiac studies will be done with the ultrasound of the heart or the transesophageal echocardiogram, that's when ECMO can be removed eventually. Now, that's assuming, there's no other issues. That's assuming there's no other complications, right? And that's what you can expect, right? So the cardiologist will keep a very close eye on here and will make the decision together with the ICU team, right? But he will certainly have to take some hurdles because he can't be on ECMO forever, right? The question is, how old is your dad? Because if, God forbid, he can't come off ECMO, is he a candidate for a heart transplant, right? He might end up on a heart transplant list, right? But that is what you should expect in a situation like this. There probably won't be any quick wins. It'll probably be a gradual process, right? It'll be a gradual process to wean him off ECMO. And hopefully, there's also now a timeline. He can stay on the ventilator for 10 to 14 days before he might need a tracheostomy. But if he stays on ECMO for more than 10 to 14 days, as much as I say he needs a tracheostomy if he can't be weaned off the ventilator, the challenge with someone on ECMO is a tracheostomy is often delayed if patients can't come off the ventilator because they need the heparin, the blood thinner, and that is almost a contraindication to do a tracheostomy, right? So your dad is certainly in a precarious situation right now, but at least he's alive, right? At least they're doing all the right things, right? And hopefully his heart will simply recover. And if his heart continues to recover, that's when they can hopefully gradually reduce the support from the ECMO and hopefully gradually but surely remove the ECMO and let his heart beat by itself. Okay, so I am going to wrap this up in a minute here, right? If you have another question, type them in before I wrap this up. I do the YouTube lives here weekly. I do them on a Sunday at 10:30 a.m. Sydney, Melbourne time in Australia, which is 8:30 p.m. currently in the US Eastern Standard Time, which is 5:30 p.m. Pacific Time, right? And also, if you like the video, give it a like, give it a thumbs up, right? Subscribe to my YouTube channel for regular updates for families in intensive care. And if you're a subscriber, you also get a notification for the YouTube Live, right? I post here almost daily, make videos for families in intensive care and intensive care at home almost daily, right? So, once again, with Intensive Care Hotline, we also have a membership for families of critically ill patients in intensive care. And you can become a member if you go to intensivecarehotline.com, call us on one of the numbers. And if you go to the intensivecarehotline.com, the membership link, or you go to intensivecaresupport.org directly, you can become a member. In the membership, you have access to me and my team 24 hours a day in a membership area and via email, and we answer all questions intensive care related. In the membership, you also have exclusive access to 21 ebooks and 21 videos that I have personally written and recorded, making sure you make informed decisions, you have peace of mind, control, power, and influence, so that your loved one gets best care and treatment. I also do one-on-one consulting and advocacy over the phone, Zoom, Skype, WhatsApp, whichever medium works best for you. I talk to you and your families directly. I talk to doctors and nurses directly. I handhold you through this once-in-a-lifetime situation that you can't afford to get wrong. I also talk to doctors and nurses directly, and I ask all the questions that you haven't even considered asking, but you must ask when you have a loved one critically ill in intensive care. I also represent you in family meetings with intensive care teams. We also do medical record reviews in real time so that you can get a second opinion in real time. We also do medical record reviews after intensive care if you have unanswered questions, if you need closure, or if you are suspecting medical negligence. And all of that you get at intensivecarehotline.com. Call us on one of the numbers on the top of our website, or send us an email to support@intensivecarehotline.com with your questions. And with intensive care at home, we are currently operating all around Australia and all major capital cities in all regional and rural areas. We are providing a genuine alternative to a long-term stay in intensive care. We're sending our critical care nurses into the home predominantly for long-term ventilation and tracheostomy, for ventilation without tracheostomy, such as BiPAP, CPAP, tracheostomy care without ventilation. We are also providing level 2 and level 3 NDIS support coordination. We are an NDIS approved service provider, TAC and WorkSafe in Victoria, iCare in New South Wales, NIISQ in Queensland, as well as DVA all around the country. Our clients have received funding through public hospitals, departments of health, as well as private health funds. And if you're an NDIS support coordinator watching this, and you are looking for nursing care for your NDIS participants, please reach out to us as well. We can help you with nursing care as well as with the advocacy. We're doing NDIS specialist nursing assessments as well. And we are providing care once again for predominantly for long-term ventilated adults and children with tracheostomies, BiPAP, CPAP ventilation, tracheostomy care without ventilation, home TPN, home IV potassium, home IV magnesium, and so forth. Also palliative care, also emergency department bypass services. Now, I'm going to wrap this up. Leave your comments below. Let me know what topic you want me to cover next time, right? And go and check out our websites, intensivecarehotline.com and intensivecareathome.com. Call us on one of the numbers on the top of our websites. Send us an email to support@intensivecarehotline.com if you need consulting and advocacy, or if you need home care. Email us to info@intensivecareathome.com or call us at intensivecareathome.com. Thank you so much for watching. This is Patrick Hutzel from intensivecarehotline.com and intensivecareathome.com, and I will talk to you in the next few days. Take care.